Hello, everyone, and welcome to the program. Today, we will be starting shortly in about 3 minutes from now. And again, you know about all this, series with Prof.Atul Goel, and it will be also live on a Chinese channel, available in live Mandarin translation. Thanks to my friend Dr. Yu Jiandong. Who will be joining us today live as well. So please use the chat box to send your questions and your comments and everything that you wish to discuss after this session. I hope you will like today's session as well. The recording will be available after the webinar. I will also share a link for you to obtain your attendance certificate. And I hope you will enjoy the show. Please use the chat box to share where are you watching the program from. And I will be happy to, know from where you are watching us live. Thank you very, very much. Hello, sir. Professor Atul, can you hear me?
Yeah, I can hear you, but let me see.
Hi, sir. Hello, sir.
Hello, Noor, how are you?
I'm doing great. I'm doing great, sir. Thank you very much. How are you today, sir? Thank you very much.
Very good, very good. Everything okay? Everything fine? What is the news
Every
from you?
Yes,
What?
sir. I'm sorry. There was a little interruption. Please, can you repeat kindly?
I hope everything is okay with you, Noor.
Yes, sir. Everything is perfect with me. Thank you very, very much, sir. I hope everything is good with you as well. I've been, watching all your wonderful activities around the globe. Sir, you are an inspiration for all of us for what you do and what you do so much with so much devotion and dedication, sir. Thank you very, very much. And I think that I cannot put into the words how much it means to me to have you here with us so regularly and to have this very, to have this very priceless chance of learning from you, from your expertise and from your experience. It means so much to us.
Thank you, Noor.
Sir, would you like to press your
Yes,
screen?
should I put my screen on? Yeah, just a minute.
Yes, sir. I believe is it Dr. Siu Yandong? Uh, um,
Can you see my screen?
yes, sir. Sorry, we can very well see your screen.
So should I put the screen off or on? Keep it on?
Sir, as you like, if you can, I will just give a very brief discussion. I think it is the right time to start our program. But would you like to start it now, or should we wait for a minute or two?
Let us wait for a minute or two. Okay?
Sure, sir.
Okay, okay.
I believe that people are starting to, they're keep joining in as we talk. They are here and they're joining in. And then it will be also live on neurosurgical.tv as well as in Chinese channel.
Okay.
Thanks to my friend Xiu Zhendong. I think I saw him somewhere in the list. I
Let him
cannot see
come.
him.
Let him come and join. Okay?
Yes, sir. I will give him a message also so he can see us. I've sent him a text.
Okay, okay, okay. Let us wait for a few minutes and then we can start. Okay?
Sure, sir. Thank you very, very much.
Okay, okay.
Sir, I hope everything is good by your side, good at your end, everything is good.
Yeah, yeah, yeah. Busy, busy, very much busy.
Yeah. So you just had a very wonderful meeting. I saw the picture yesterday all over on WhatsApp and on social media. It was a very brilliant one, sir.
Yes, vascular meeting, very big
Very,
meeting.
very good.
And many people from all over the world had joined. And
Yes.
good learning, good teaching, good interaction, and everything went well.
Exactly. It was a perfect meeting because, I also saw post by Dr. Daniel Walsh. He really appreciated everyone there. He said that I'm so much impressed. I think he's never been to India that many times. So he was like, wow, everyone was so much enthusiastic. The teachers were amazing. And he wrote a very but beautiful message to the attendees and to the faculty. So it was great. I can just imagine. It was a wonderful week.
Let us begin, Noor, instead of waiting.
Yes, I believe so. I believe so. Sir, I will just give a very brief introduction. Obviously, you don't need any introduction, but for the sake of formality, it is an honor to welcome the legendary Professor Atul Goel today with us. And obviously, you know him so very well. Everyone in neurosurgery, whenever you join neurosurgery, I think Professor Atul Goel is one of the first people you come to know about, especially when you open the book, you read about cranial-cervical junction. You do take interest in school base or in spine. Professor Turgoyle is the person who comes into your mind for the first time. So I was so much amazed. One of my own mentors, my madam, she called me and said that I use a lot of techniques by Professor Atul Goel. So whenever I see the show by you, I feel so much excited and so much proud that you are conducting such a wonderful personality in the webinar series. So, sir, thank you. First of all, thank you very much. I know you have been so much busy, but still, it is so kind of you, and it's your greatness that you always spare time for global education. So, ladies and gentlemen, today we are having Professor Little Goel with us to deliver another state of the art lecture. This time on you know on the surgery for spinal degeneration, introduction of a revolution. Professor Goel is also current head of the department in the Leeravati Hospital. Previously, a few months ago, it came into a lot of limelight thanks to Saif Ali Khan. He was also, I think, he was also treated in Leeravati, and everyone was like, "Oh wow!" This hospital was. Like all the laymen also came to know about this hospital. It was a perfect facility for learning. And I think your doctors, your residents, and your patients are all equally lucky to have your kind presence. So thank you very much. The podium is all yours now. Thank you very much, sir. Take as much time as you like. We are all staying glued and so much grateful to you.
Thank you, Noor. Let me share the slides. Wait. Okay, Noor, can you see the slides?
Yes, sir. It's perfect.
Okay, so what? Just a minute. Just
Yes, sir.
so what I'm going to do is, you know what, I'm going to talk for a few minutes on craniovertebral junction lecture I have already given in my last edition. But to give you update on what I'm going to speak on, let me talk about 10 or 15 or 20 minutes on craniovertebral junction, and then I'll go further on spine. I'm going to repeat many of these slides because it is so important and so critical and so different from what is written in the world literature. It's completely different version of spine surgery. And that is why I have no hesitation to say that I am going to present a complete revolution in spine surgery, not only subaxial spine, but also craniovertebral junction region. So when we think of spine, we look at the images, we look at MRI, we look at the site of compression, and we go for decompression. That is the standard treatment all over the world for any kind of spinal issue. So what I'm going to say is that we should not just worry about images. We should not just think about decompression. So I'm going to present a complete different version of spine surgery, and that is compression is never primary. Compression is secondary to unstable spine. Compression is protective or adaptive. And most important is compression. You do fixation, compression gets reversed. So this is a very, very big statement to make. And the other very huge statement to make is that decompression is never the treatment. So you can imagine what a different version of spine surgery I'm going to present. Decompression is not an issue. Of course, I'm not talking of tumors and all. So this is my very favorite slide. All the muscles of the back are focused on the facets. There is nothing near the disc, nothing near the vertebral body, very thin and flimsy muscles. All our muscles are focused on making the human body stand. All our muscles are focused on the facets. When these muscles, and if you know, as I have said previously, if you open your mouth, you can feel, put your finger inside, you can feel the odontoid process. You put your deepen your finger in the neck, you can feel the vertebral bodies. Here on the back of the neck and back of the spine are the muscles. And when these muscles become weak due to disuse, abuse, or whatever you can say, there is instability at the facetal articulation, instability. And this instability is the problem. This instability is the beginning of all problems. It is the mother of spinal degeneration, not the disc. Disc is divine. Disc can never go wrong. Problem is you, because you have not taken care of your muscles. They become weak and the spine becomes unstable. So all our muscles are focused on the back of the spine, unlike bird where the muscles are focused on the shoulder, four-legged animal on the shoulder and hip. Nothing too much on the spine, nothing too much on the spine. Here, all muscles are focused on the neck and spine. All muscles are focused to keep the neck extended and sitting and standing position. So when these muscles become weak, the human body bends, and you are over the period, you can become four-legged. You bend, 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 go like that. And if you just don't take care of the muscle, you will become like a horse. So I introduced this concept of vertical facetal instability. Vertical, when these muscles become weak, there is listhesis at the facet. Listhesis. And this listhesis is the cause of spinal spondylotic disease. I call this instability as vertical facetal instability. Vertical, not axial or transverse. So, as you know, for basilar invagination, the whole world was doing decompression either from front or from behind. In 2004, we said that this is unstable. You can do realignment and fixation. There is no need for decompression. And later in 2013, we said that this carry and syrinx is due to unstable craniovertebral junction, and there is no need for foramen magnum decompression. So you have heard me talking on this subject several times. Just to summarize, so this is basilar invagination. The whole world was doing transoral decompression. So we said no decompression, stabilization. And now you see this kind of realignment and stabilization. We have got hundreds and hundreds of patients now where we have said instability is the problem. Compression is not the issue. Decompression is not the treatment. Stabilization is the treatment. And we have completely removed back transoral surgery from the books of neurosurgery, and they are in the historical domain. No question, no doubt in this. And also, you must remember, whatever I am speaking, I have no doubt at all. And whatever I am saying is published. Not one word is not published. So in 1999, we said basilar invagination is nothing but listhesis of C1 over C2, like spondylolisthesis. So this is basilar invagination, basilar invagination. Listhesis is the problem, instability is the issue, and stabilization, no decompression. So this is what we have said in 1999. So you can imagine 26 years ago. About 15 years ago, we introduced a brand new concept of central or axial atlantoaxial instability. Believe me, Noor, this is a revolution in craniovertebral junction. Revolution. You will ask me why? Because this instability nobody has yet understood. This instability is the cause of Chiari, syrinx, and several other things which I will talk today. So let me just say this is in 1999 we said listhesis is the problem. Listhesis is unstable stabilization. Now you see these two slides. Basilar invagination, the whole world will do foramen magnum decompression or syringostomy. There is no atlantodental interval disturbance, but there is a facetal malalignment. This is unstable. This needs stabilization. There is no doubt. So these kind of patients where decompression is the current treatment in the world, I am saying you do C1, C2 stabilization. So this is a revolution. Similarly, see this one, there is no atlantodental interval disturbance, there is Chiari, there is syrinx, there is no facetal malalignment, but Chiari and syrinx, assimilation of atlas, basilar invagination are all secondary to unstable C1, C2. Stabilization is the treatment. This is a completely different version of craniovertebral junction. Now, see this. This is a very shortest, not a big slide. There are many more things which I have not mentioned. Chronic atlantoaxial instability. is the cause of C2-3 fusion, triple five, platybasia, caries, syrinx, basilar invagination, short neck, bifida, occiput, and so many things. Also, when basilar invagination is present with carie, or carie is present with syrinx, or syrinx is present alone, or carie is present alone, or basilar invagination is present alone, means either discretely or in cohort, they indicate unstable atlantoaxial joint and they indicate the need for one treatment, atlantoaxial stabilization. You know it, that all these things which are mentioned here, majority of things are even today not in the world now, but at least lot of world is being treated by decompression. I am saying it is a negative form of treatment. So when there is basilar invagination, atlantoaxial. When there is carie, atlantoaxial stabilization. When there is C2-3, atlantoaxials. When there is kyphoscoliosis, I will talk on this subject very briefly because I have talked in my previous lecture. So basilar invagination, syringomyelia, carie malformation, are all children of atlantoaxial instability. So when I wrote this article in 2013, there was a lot of controversy, and even today there is a lot of controversy. We said that Chiari is due to unstable atlantoaxial joint, and atlantoaxial stabilization is the treatment. If you ask me today, if you start discussing and arguing with me today, I will say just don't bother discussion. This is a finished story. Accept it and learn the art of C1, C2 fixation and do it rather than discussing and troubling your mind unnecessarily. Even when there is no facetal malalignment, you have to do C1, C2. And if you see your next patient of carie, you remember to see the neck. There will be spasm, there will be pain, there will be restricted neck movements, there will be hand problem, there will be difficulty in talking, difficulty in sleeping, and all those things. Chiari syrinx, children of atlantoaxial instability. Stabilization is the treatment. Magic is the radiological result, and more magic is the clinical result. And now we have got several hundred, more than 600 patients where we have not done any kind of decompression, only stabilization. The tonsil can go up, syrinx will reduce in 100% of patients, and even if there is small little instability, now we have started talking of, you must read my recent paper on dynamic imaging on head rotation and head tilting, and this kind of syringomyelia reduction in 100% of cases. So even when there is no atlantodental interval, no facetal malalignment, there is no tight posterior fossa. This concept is mine. We said for the first time that there is tight posterior fossa in 1998. Now we said if you see the subarachnoid spaces, if you see the fourth ventricle, if you see the CSF around it, there is no question, no tight posterior fossa. So the syringe can reduce in 2 or 3 days after surgery, but in almost 100% of patients, if you do scan after about 6 months. So immediate post-op after 6 months. So this is my article. Please read it. I don't know how to tell you other than saying, giving my lectures and tell you to read. And if you have confusion, please read it. If you don't have confusion, then please do it. And if you have confusion even after reading, you please come to my place and we will discuss and show you several things. So carie syrinx are all children of atlantoaxial instability. They are naturally protected. These things are protected and secondary to unstable spine. So chiari is a formation, not a malformation, and it is like a nature's airbag. In 1996, can you believe 1996, about 30 years ago, this is my editorial, Syringomyelia, a natural protective phenomenon. So when I said chiari is present with syrinx or without syrinx, or syrinx is present with chiari or without chiari, or idiopathic syrinx, this is due to unstable atlantoid. Nobody knows what to do for this. The whole world there is only one treatment of syringostomy. Don't do it. Do C1, C2 and see fixation and see the magic. So these kind of short neck torticollis are all secondary to unstable atlantoaxial joint. They are children of atlantoaxial instability. cervical fusions like clipple 5, C1 assimilation, C2-3 fusion, multi-leg segmental clipple file are all based on chronic atlantoaxial with no compression. So spine surgeons should stop thinking about compression and stop doing decompression. So this kind of kyphoscoliosis in the presence of carry and sitting, there is no question. Don't start doing multiple rods and all those things. This patient needs C1, C2 fixation. Even when there is this kyphoscoliosis can be present discreetly, even without carry and without syringe and without basilar invagination. And this age group patient, central AED should be considered when you think about treatment. So central or atlantoaxial instability, you see presence of small little syringomelia, presence of bifid, even in the absence of compression, even in the absence of atlantodental interval disturbance, even in the absence of facetal malalignment, you do fixation C1, C2. This is a complete revolution in craniovertebral junction surgery. And nobody who is listening to me should have any kind of doubt or any kind of counter thinking about this. And as I have already said, all these things are published heavily in the literature. So foramen magnum decompression, in my view, is a completely negative and a historical operation. Now, I'm going to touch on another subject, which I have also talked on several occasions, not on Noor's platform, but I'm going to talk on your platform, Noor, today about cervical and lumbar degenerative radiculopathy and myelopathy. And I must tell you that I was very good in anterior surgery, and I wrote several book chapters, including in Sweet and Smidek several years ago. And these kind of anterior decompression, discectomy, corpectomy, and all those things were very regularly done in my department. And this kind of fixation was regularly done. And I also described this tricortical screw fixation, which is now people transdiscal screws for lumbar spine and for cervical spine, and standalone screw fixation. So I was good in anterior surgery. Now today I'm going to talk on degenerative arthritis of craniovertebral junction and subaxial spine. As I said, that the whole system of muscles is focused on the facets. So in 2010, 15 years ago, for the first time in the literature, now listen carefully to my statement. First time in the literature, we had said that degeneration of craniovertebral junction is due to craniovertebral junction instability. And in this article in 2010, we said that only stabilization and no decompression is necessary. So this is the article published in JNS Spine. You please read it. So here we said that instability is the issue, these osteophytes and all those things. So carefully look at this slide, carefully. Even if you have seen it, no harm in seeing it again. Because I have shown it 200 times, so you must have seen it 3 or 4 times. So let's see it fourth or fifth. Reduction in the joint space. You see joint space reduction? Buckling of this ligament, osteophyte formation are not primary processes. They are indicators of chronic atlantoaxial instability, and they are naturally protective or adaptive processes. Osteophyte formation in the tip of odontoid process, behind the odontoid, front of odontoid, are not primary. Don't do decompression. They indicate unstable atlantoaxial joint. You stabilize. Decompression is not the treatment. Retroodontoid pseudotumor. Believe me, the whole world was doing decompression. Whole world. By transoral, by lateral, decompression was the treatment. And if you are more than 20 years in neurosurgery, you must have seen and you might have even done decompression. But for the first time, we said that atlantoaxial instability is the cause of retroodontoid pseudotumor. It is like a big osteophyte. You stabilize, osteophyte disappears. These kind of osteophytes, you see, these are osteophytes. These are not tumors. They were called pseudotumors. But this article was the first in the literature not saying that retroodontoid pseudotumor is an evidence of craniovertebral junction instability. So don't look at compression. Oh, cord is compressed. This is decompression is required. Nerves are compressed. Don't worry about compression. Remove that. So this article, 21 years ago, atlantoaxial instability was published in Japanese Journal of Neurosurgery, 2004, where we said atlantoaxial instability and retroodontoid mass. Retroodontoid cyst, very easy to remove, but whether it is necessary to remove or not. You see, there is unstable, there is assimilation of atlas, there is central instability. You stabilize, the cyst will disappear. Treatment is not decompression of the cyst or removal of the arch and this and that. You do C1, C2, it will disappear. You see, this is another cyst, and we have got several cases now in my series when nothing has been done to this, just C1, C2, and you can imagine what a different treatment, what a different concept. No question, revolution. No question, revolution. Facets are not in a problem, odontoid is not in the problem. Do fixation, cyst disappears. Retroodontoid or body tumor or pseudotumor or pseudocyst. You see, there is a hole in the bone. There is a dynamic process. Flexion, extension, the cyst goes up and down. Ostodontoidy. Here, don't start doing decompression. Don't start removing the body. Do fixation, and the matter is treated. And this is another case. You see, there is a hole in the body. There is a dynamicity. Flexion, extension changes. This kind of pseudotumor is not tumor, it is not TB, it is unstable age-related, unstable spine. Stabilization is the treatment. So, my dear friends, please read this article and you might just get some beautiful information that is not there in the literature. So, that is different, and that is a different version of spine surgery. You will be surprised that the whole world was doing Panus resection and rheumatoid arthritis by transoral surgery and then they occipitocervical fixation. This was regularly done. So we introduced in 2004, actually, I said that this Panus is secondary to vertical instability. You stabilize, Panus disappears as early as immediate postoperative. You can imagine what a different format of treatment from decompression to stabilization and vertical instability as the cause. Pseudotumors like this can disappear immediately after surgery. You see, in the immediate postoperative period. So we had introduced this intra-articular implants, and many of you have heard it, many of you have seen it, and many of you, and some of you have used it. But you have started using it. I have little bit retracted from using these intra-articular spacers, which are my patented product. These spacers are patented in US and in several other countries, and in India, of course, it is. So these are the intra-articular joint jamming as the treatment we said. Now I go to subaxial spine. Carefully see, my dear young, I can see that most of the people watching are young people. So please keep your mind open and keep your mind supple rather than fix your mind. Fix, compression, compress. Don't fix. Decompress your mind for the time being. Listhesis at the facet due to muscle weakness. Listhesis means there is a slipping. If you see your grandfather is shorter than you. Why he is shorter? Because there is multi-segmental listhesis. That does not need treatment. If there is a neurological deficit or neurological symptom, then of course it needs treatment. And that symptom also, if it is mild, you can do exercise and recommend exercise and there is no need for treatment. So this listhesis is the cause of spinal degeneration. Now, my dear friends, carefully look at this slide. Reduction on the interbody space, osteophyte formation, bulging of these discs, are not primary events. They are secondary to segmental or multisegmental unstable spine. They indicate instability. They are naturally protective and they are adaptive and they are reversible following stabilization. So imagine this is a complete revolutionary concept. I want you to listen to this concept very carefully. This kind of multi-segmental bone fusion, these are not, the person was not born with this bone fusion. These are secondary to very severe instability. These are naturally protective. And if you don't treat them over the period, this natural protection, this disc which is divine will give way and the whole thing will fuse. Ultimate will be fusion. But instability is the cause and stabilization is the treatment. These kind of bone formation, new bone formation, and evidence of bone fusion is an evidence of unstable spine. So you see this bodies, how they are, this osteophytes, multisegmental, degeneration at the facets, osteophytes at the facets. These are all indicators of unstable spine. These kind of, you know, crocodile kind of osteophytes, they are not, person was not born like a crocodile. This crocodile you have made because you have not exercised enough. And this crocodile can be treated properly by, you have to sacrifice your movement in some segments and the crocodile will disappear. So in 2010, 15 years ago or more, this is the paper which was published later, we introduced this concept of intra-articular spaces. So put intra-articular spaces in the joint, it is distraction and stabilization. So you can imagine this concept that there is no decompression, but there is distraction of the facet and stabilization. At that time, we did several cases. You see this ligamentum flavum buckling, osteophyte, posterior longitudinal ligament buckling, distraction of the facets by spacers, and putting bone graft from the iliac crest. And these were the spacers. You see, this is immediate post-op. These bulges have gone, these ligaments have straightened, and most important is the patient dramatically recovers in the evening of operation. You see this bulge, you see this new disc formation, you see this ligamentum flavum hypertrophy, this is straightened, and this is the intraarticular spacers. This is multi-segmental spacers. So essentially what we did was, from the concept of decompression, we introduced the concept of stabilization and arthrodesis without decompression. And we had several patients at that time. You see here, this is post-op, there is bone fusion. And there is multi-segmental bone fusion with spacers. There is no decompression of any kind. This is another patient. You see this, the cord, and you see the beauty. There is new disc formation following spacer introduction, and there is no decompression. So this article, whatever I'm saying, is heavily published. You must remember this. And in the leading journals of the world of spine and of neurosurgery. So facetal distraction as a treatment of cervical spondylotic radiculopathy. And so this was published as a cover page illustration in JNS Spine in 15 years ago. Same concept we use for lumbar spine. Lumbar canal stenosis, what you do? Decompression. What do you think about this? You think that they are compressing. They are the problem. But if you think they are not the problem, they are protection. They are secondary. They are adaptive. You introduce these spacers, distract, fix, and this article was also published about 15 years ago with 21 cases in JNS Spine where we talked of these spacers. And we did these kind of cases, you see, multi-segmental for failed decompression, for primary decompression. And this was the article where my another colleague from Italy had introduced in his article with me on lumbar facetal distraction. So this facetal distraction concept completely changed, or this was a new version of treatment of spinal degeneration. And these were my spacers. And during my journey, I also introduced mobility and distraction. So this kind of ball and socket joint, which was also heavily patented, this thing. And so it causes distraction, it causes stabilization, and it retains movements. I don't use them. So there is a possibility of an artificial atlantoaxial joint, and there is a possibility of these kind of models and various kinds of models that we introduced. We did this study on the basis of very heavy anatomical work on morphometric analysis of cervical spine, morphometric analysis of lumbar spine. So we introduced these intra-articular spaces. You just carefully look. These are immediate postoperative images. You see this bulging of the ligaments. You see little bit bulging of ligamentum flavum, and you see this immediate postoperative period, and this is after a few months of surgery. Most important thing is there is no decompression and stabilization. We also talked about disc herniation and postoperative reversal. You see, there is a disc. We did two segment, and this is immediate post-op. You see, this has disappeared. I don't do it. I don't recommend it, but I have just published it. Just see it. Okay. So we have been doing decompression for a long time because we think that the compression or deformation is the problem. That is basic. Anyone has confusion, there should be no confusion. This is the concept, and this is the existing concept. In 2013, we introduced another concept. We changed from distraction. We said there is no need for decompression, direct or indirect. You do only fixation, not even distraction reduction, only fixation. And then more recently, we published our series 5 years ago with 215 cases. Now our series is far beyond. Now you see, this was in World Neurosurgery. You see the title, muscle weakness related spinal instability is the cause of spinal degeneration, and spinal stabilization is the treatment. Can you believe this? There is no talk of decompression. So this is different. Now I'll show you some slides. You see this compression, and you see after 18 months of surgery, there is only stabilization, and aim is arthrodesis. This is another multi-segment. What you will do, think about it. What you do or whoever does, the gold standard treatment for such multi-segmental is wide decompression. Some people do laminoplasty. Some stronger spine surgeon, stronger by hands, not so much by brain, maybe they do multi-segmental corpectomies and discectomies and all. And I can also tell you, multi-segmental corpectomies, if you read the literature, if you have done more than 3-level corpectomy, the complication rate is more than 35% from the leading authors on spine surgery. So don't take that this corpectomy is a very simple procedure. And this procedure is, you can believe it, I do 5-level fixation in 10 minutes. Such a strong fixation under vision, and facets are the strongest point of the spine, and you see the beautiful radiological result, and you have to come here to see my beautiful post-operative magical outcome. So this is multi-segmental degeneration. There is no decompression. You see, you will say, though there is severe compression, how can compression be not treated? You have to do decompression. This is not yours. The whole world will say like that. But you are witnessing a revolution. You are witnessing a different version of spine surgery, stabilization and no decompression. So this is another case. You see, after some time, you see this multi-segmental, you see after some time. If you carefully look at this slide, you will see how the whole story, this patient, of course, I cannot show you, but he was remarkably better. So degenerative spine, we should look in a different version with a different mindset in terms of instability, not in terms of compression and decompression. Instability is the cause of symptoms and stabilization is the treatment, not neural deformation or compression, but instability is the cause, because I have done only stabilization and the patient recovers in symptoms. It means compression was not the cause, instability was the cause. And I have not even done distraction. So symptom of lumbar radiculopathy is an evidence of unstable spine. Focal cord atrophy is a chronic unstable vertical instability. Another big issue in spine surgery is, you see, there is 2 levels of compression. And I have done 4 or 5 levels of fixation. So why 5 level of fixation in 2 level? That is the issue, and that is the question, and that is what you have to read my papers. Why upper level fixation in lower level? That is very, very important. This is 3 level compression, and I have done 4 or 5 level fixation. You see the beautiful post-operative radiology, but what you have not seen and what I have not shown is the remarkable clinical recovery in all these patients. Magic. My key word in my presentation here in front of you is the term magic, is the term revolution, is the term different. So this kind of compression, only fixation is the trick. Another beautiful thing is nobody in the world talks of atlantoaxial instability in degenerative spine. So this article was one beautiful article where we said atlantoaxial instability is can be present in degenerative spine. So if you see there is multisegmental compression, there is nothing at the C1, C2. Look at the facet. This is clearly unstable, needs stabilization, not decompression. We have recently described another method of C1, C2, 3 stabilization without putting the screw in C1. So I have not put the screw in C1, I have put screw in C2, 3 and removed the C2 spinous process. That is a different way of achieving atlantoaxial stabilization, multi-segmental stabilization, no decompression, remarkable clinical outcome, remarkable. So you see this compression kind of story, and you see this has disappeared. Cord has become big, cord has become normal. I have put 2 screws. Sometimes I put 2 screws in cervical spine. Most of the times I put 1 screw. And when the patient comes with severe myelopathy, atlantoaxial instability is almost always present. You have to include C1, C2 in your fixation construct. You see here compression. You see after period of time I have done direct C1, C2 in this one, but nowadays I don't do direct C1 screw implantation. Lumbar canal stenosis. What is your impression? Tell me, my dear young boys and girls and men and women, what you understand about lumbar canal stenosis. You understand that there is stenosis of the canal. Yes? Now you see this neurosurgical focus, the title. Analyzing the role of stabilization and futility of decompression. You see this word futility in neurosurgical focus. It is a big journal. So this kind of lumbar canal stenosis, I don't do any kind of decompression, only stabilization. Lumbar canal stenosis, claudication pain. There are several articles of mine on this subject where I'm saying that this is unstable, this is secondary, needs stabilization, and I have done so many cases of lumbar canal stenosis, and you have to just believe me. I know some of my patients could have gone here and gone there, but none has come to me. I've never repeated an operation after I've done only stabilization, and I do transarticular fixation like Camille's technique. So when there is failed lumbar canal stenosis, you do only fixation. So you do lumbar laminectomy, which should not be done. Laminectomy, and you will say I use endoscope for decompression. Don't do decompression. No, I use uniportal, I use biportal. Yeah, they are good, but what I am presenting is a different concept. I am presenting a new version. I am presenting you a revolution. So there are 2 screws here, and this is transarticular. In young, the lumbar canal stenosis is different. In old, it is different. So the question is, should you remove the osteophytes in degenerative myelopathy? I have already answered that osteophytes are secondary, osteophytes are protective, osteophytes indicate unstable spine, osteophytes are reversible. So this article, please read my article where I have discussed, and this is in World Neurosurgery, where we have said that what happens to osteophytes after only fixation. And some of these pictures you see, and you see the whole thing is this shadow inside the cord does not disappear for a long period of time. And I am recently working on one new article on what is the shadow. And this shadow initially is due to vertical instability. And what happens to this shadow after a period of time, I will come back to you very soon. So this kind of osteophytes, multi-segmental osteophytes, need only, and these osteophytes which are divine intervention will regress. So spinal canal stenosis is a misnomer. You should call spinal canal instability. Another beautiful thing is this kind of kyphosis, and the kyphosis is not a primary event, it is secondary to unstable spine. You have to identify the unstable segment and stabilize, no decompression. So you please read this article, role of atlantoaxial and subaxial instability in the pathogenesis of kyphosis. Now don't start doing kyphectomy and osteopectomy and all those very attractive words. You use do simple stabilization and you see magical outcome. This kind of kyphosis, this kind of compression, you have to do just don't come from front and start removing this osteophyte. Don't come from back and start doing laminoplasty. For this kyphosis, even when there is no compression, you have to do multi-segmental stabilization. So you understand the difference in the existing literature and the concepts which I am presenting. Now, this is a little bit, I'm still working on it. I have written several articles on this, but you can, if you want, you can just ignore it for the time being. Herniated disc. What you do for herniated disc, you remove the disc. I am saying that herniated disc is a manifestation of unstable spine, except for extruded disc in young people. I don't remove the disc now. And only spinal fixation is the treatment. So is this dissection necessary? I will say this, like this ACDF is a established procedure. But if you do only fixation after 6 months, this will disappear. And there is no need to remove the disc. This disc is when you lift heavy weight or you do sudden jerk, there is sudden ligamentous injury, and this herniation is the result. Protection. This is secondary. Disc is never wrong. Disc is always protected. You stabilize, the disc will disappear. And we have got several hundred beautiful cases where we have not done and published. This is in World Neurosurgery. You can read this article, facetal fixation arthrodesis as the treatment of lumbar, also published, where we have talked that lumbar disc should not be removed. You stabilize, the disc will disappear. You see this disc disappear after 6 months. Another thing, lumbar scoliosis, lumbar de novo scoliosis, idiopathic. We call it idiopathic. But what I say, it is not idiopathic. It is due to unstable spine. This kind of idiopathic, read the literature. The whole world will say decompression and all those things and all those things. And this patient is very high profile person, president of one country. I don't want to name the country, but a president. And for the president, I have done only stabilization, and magic is the clinical result. OPLL, OPLL is a very difficult, dangerous chapter of neurosurgery and spine surgery. And believe me, I was very, very strong in OPLL surgery. I described for the first time oblique corpectomy for OPLL in 20 years ago. So this picture was in my article where I did corpectomy oblique, and I said that stabilization can be avoided. But now what I'm saying is only stabilization is the ideal treatment for OPLL. OPLL is a secondary manifestation of chronically unstable spine, special neck. They have large neck like a hippopotamus. They have large body like an elephant. You see your next patient of OPLL, most of them are bulge, huge, strong guys. They need only fixation because they have never exercised their bodies ever in their lifetime. So these kind of OPLL, only fixation. Atlantoaxial instability is very frequently associated. You see, I have done, there is central instability, I have done C1, C2, and only fixation. And now I don't include C1 screw in the fixation construct. So this is another case and another case. And you see, this is the new technique which I do. I don't put C1 screw, but this is an alternative method of C1, C2 fixation. Another disease which nobody in the world knows what to do and how to do and what it is, Hirayama disease. But you see this beautiful article, completely you give new life to these patients. Stabilization is the treatment. You see this Hirayama disease on flexion, there is this shadow here. Most people do some dural tenting kind of thing, and many people do corpectomies for this kind of problem, but this needs only stabilization, and the only one result is a magical recovery. So can atlantoaxial and subaxial spare stabilization revolutionize the treatment of OPLL? My answer is loud, and my answer is clear, and my answer is definitive. Yes. I use the Camille's technique, transarticular. For cervical spine, I use only one screw and only rarely two screws. These two screws, I call them double insurance screws. For lumbar spine, I sometimes use three screws or two screws. I call them triple insurance screws. So can decompressive laminectomy go into books of history? Like I have put transoral surgery in a history book. I have put foramen magnum decompression in history books. I have a feeling this laminectomy and endoscopic biportal, uniportal can go into history books unless they do this kind of. So transoral surgery can anterior cervical spine surgery form in the books of history. So this is from only decompression. The whole world is not world, it is doing only decompression for multi-segmental stabilization to only fixation, a century-long journey of spinal spondylosis. So, my dear friends, young boys and girls, ladies and gentlemen, dear friends, think about it. Don't become emotional. Don't become irritable and aggressive with me. I am giving you a concept. It is on you whether you take it or leave it, accept it or reject it. But this is a concept I am putting forth you, which is heavily published. And a huge number of patients I have treated over the years with magic result. Compression is never primary, and decompression is never the treatment. So, my dear friends, thank you very much. And I hope you have enjoyed this unusual kind of presentation. And maybe it has given you some food for thought. Maybe it has given you some ideas. Maybe it has given you confusion, but at least something different from what you have heard and what you have seen and what you have done. Thank you very much, Noor.
Thank you very, very much, sir, for your amazing, amazing, amazing talk, which was very, very enlightening, very insightful. And no matter how many times we even listen to the same thing or same cases, you always give another new, something new for us to think about, sir. You are doing something which I cannot even, I cannot find even words to express how much it means to me. So thank you so much. And I know that everyone really enjoyed the talk, and they are sending you a lot of messages. And there is also, sir, I'm so much pleased to tell you that Professor Ahmad Al Khani is with us today. Professor Ahmad Al Khani, who is the current chair of the Functional Neurosurgery Committee of the WFNS and also the ex-president of one of the Saudi societies of minimal spine surgery, I believe. So, sir, I can tell you that everyone is so much amazed. Sir, would you like me to invite Professor Ahmad Al Khani to the floor?
Of course, of course. And it is my pleasure to see him. I know him. I have met him. Maybe he does not remember, but I have met him. And I will be happy to talk to him. Noor?
Thank you very much, sir. Dr. Ahmad Al Khani is joining us.
Uh,
Thank you very much, sir.
it's always my pressure. It's always my pressure, Noor. It's always my pressure to join you with your activities. But today you have selected the number one neurosurgeon in the world to talk about craniocervical junction. Who other than uh, Dr. Atul Goel going to talk about craniocervical junction? Uh, I totally agree with a lot of concepts that he discussed today. I may disagree with some, but I want to emphasize a word he put on the last slide, saying that it's never a matter of compression, it's a matter of instability. And simple decompression alone will not stop the etiology of the problem and the progression of the problem. I tend to agree 100% with what he emphasized and what he stressed on. The problem is the only solution we have is to fuse, and fusion will just transfer the load into another level. That's the problem. Maybe the future will give us some other solutions than just to fuse the cervical or the lumbar spine. But I want to congratulate you for this very fantastic organization of this session. I always like to congratulate our Professor Atul Gul for superb presentation that we are always used to hear from him. Thank you very much. I heard that a lot of audience were in this presentation, and good job.
Thank you.
Thank you, Ahmad. Where are you, Ahmad, now? Where are you?
And Riyadh just arrived home
Okay.
from the
Okay.
hospital. But your presentation is very unique, and I made sure that to attend and to support our young neurosurgeon Noor-ul-Huda.
Thank you.
Thank you so much, sir. So kind of you, sir. I'm really in a lot of depth of gratefulness to Professor Atul Goel. He's such an inspiration. Whenever he's around, it's so surreal for me. It's like a dream come true. And sir, I'm also so much grateful to you, Professor Ahmad Al Khan. He also a huge inspiration for me. And it was, I'm so pleased to tell you that actually we are also working on a project, on a group project together, so it's something which really means to me. Thank you very much, sir. I think I'm someone so much lucky. I feel myself so much blessed that I have amazing people like you around me, no matter where in the world you are. But to me, it's like a blessing. I think it's like I cannot believe it. I cannot. I'm just imagining my life in a very good way, and it's like a dream come true for me. Thank you very much for me. I actually owe to both of you for being you keep me motivated, you keep me encouraged. I think it's a blessing for me. I'm so much lucky to have you both around.
Thank you. Thank you, Noor. Thank you.
Sir, we also have Professor Gabriel Vergas with us. He's from Colombia. Professor Vergas probably would like to say hi to you. He's also a huge fan of yours, and he always join us when you deliver a lecture. He's one of your biggest fans, and I'm also. Hi, sir.
Professor Atul, how are you?
I am
I'm
very
in the middle of the meeting in an island in Colombia, San Andres Island. But nice to see you and nice to hear, as usual, your very spectacular concept on this spine surgery and the vertical instability. I want to ask you one question. My son, who is a neurosurgeon, who is with me here, asked me, oh, so this is the professor of the Goel way to put screws on the C1, C2. Say, yes, this is the man. So my question is, when do you recommend today to use screws by posterior approach, mainly on the C1, C2 stability? So what is the way that you recommend today for us in around the world that we don't have your facets material? So do you recommend to stabilize with screws?
no, no, listen, now, Gabriel and Junior Gabriel, listen. My technique is open the joint for C1, C2. Open the joint, remove the articular cartilage, put bone graft in the joint, and then put C1, C2 screws, like what we have described in 1988. So 1988, so many years ago, Gabriel, when I described this technique, and it was published in 1994, there is no question facets are the strongest points of the spine. Facet is the fulcrum of all movements. Facetal fixation is the strongest. Vertebral bodies are the weakest. Pedicles are weak. Facets are strong. So you have to put screws in the facets. Any intervertebral body fixation can be quite weak, interbody. Of course, you can put cages and all those things. But if you put the transarticular screws or interarticular screws in the facets, that is, believe me, the strongest And there is no question that is the treatment for C1, C2. And now I'm talking of subaxial cervical spine and lumbar spine and dorsal spine. So this is going to be just the future of fixation and fixation, future of degenerative spine, whether somebody likes it or not, whether somebody says, I don't believe you, whether somebody says, no, I want to, compression is too much, I can see on the MRI, the cord is thinned out 1 millimeter, the nerve root is squeezed and all those things, and I will like to remove the foramen, and I will like to remove the body, I will remove the OPLL. My feeling is whether you do it now or whether you do it today, that is all right. But believe me, after day after tomorrow, you will not do any of these things because they will become history of neurosurgery. So this is, I'm so much confident and convinced about what I am saying is, so you know what, when there is a chronic instability, nature comes in picture. Chronic atlantoaxial instability, Chiari malformation, syringomyelia, basilar invagination, torticollis, short neck, short head, bone fusions, they are all secondary to unstable spine. The primary phenomena is neck pain. Primary phenomena, neck pain to stabilize the spine. Why neck pain happens? Because to stabilize. Why neck movements are restricted? To stabilize. Chronic neck pain for 10 years, for 15 years, there is body fusion, there is assimilation, uh, there is basilar invagination. They are all secondary. Similarly, in degenerative spine, it is a chronically unstable spine. Your muscles become slowly weak. Unless there is a trauma and injury, muscles become slowly. That is why I showed one slide. What is the difference in young lumbar canal stenosis and old lumbar canal stenosis? In old, it is a chronic muscle weakness. Slowly, the muscles become weak. In young, there is some kind of injury or some kind of pull, and there is the canal stenosis is one or two or three levels. In older people, it is not just one level or two level, it is four or five levels. You don't just see compression and do fixation at one or two levels in old people. You have to do multi-segmental stabilization. In young people, you have to see the compression, identify and just do one or two segment stabilization, because if you do 5 segment stabilization in a young boy, it may be harmful for his movements and his life. So spine surgery, you see, whole life I've spent in skull base surgery, whole life I've spent in cavernous sinus surgery. But what gives me this special kind of attraction towards spine is the way you can completely create a magic with this kind of, this kind of thoughts. And on the other hand, if you treat a spine not properly, they will continuously keep on complaining, oh doctor, I'm having pain here, pain there. You do whatever kind of decompression, they will never be fully happy and satisfied. You do stabilization and you see the magic. Gabriel.
Thank you very much. Very spectacular. Thank you.
I hope the junior Gabriel liked it.
Sir, everyone likes you. You are so much popular. Everyone likes you. Oh, hi. Hi. Hi.
Hello,
Oh,
hello.
this, and
Hello.
this boy has become older now.
Yeah, I'm sorry for that. You know, this little boy always make his parents annoy, and he makes me that. I'm sorry. Thank you again. Great lectures like always. And we know the first step, the critical issue to improve ourselves is open our mind. And so if you don't know Professor Atul's concept in spinal disease, in scar base, in intrinsic tumor, in AVM, then read his papers and listen his lectures. If you if you agree his concept, then do it and apply it in your clinical practice. And if you are confused, then watch his lab surgery workshop and go to Mumbai, go to Somalia, go to Lilavati to see the amazing magic. So thank you.
Thank you,
Sir,
young
I
fellow.
had this. Hi. Sir, I had the chance of watching your live surgery earlier this year, and I was like, wow, you are such a blessed surgeon, sir. It was so fascinating to see you operating and doing all these things, and it was so much fascinating. Sir, we have got a lot of messages for you. Many of them are appreciation. I've got message from Dr. Hidayatur Rahman Safi. He's saying it was wonderful and revolutionary presentation. So much grateful to Sir Atul Goel. There's also a message from Dr. Muhammad Al Meziogi. He's saying magic, magic. It's purely magical. And sir, there was a message from Dr. Dosh Shuren by best send. I'm sorry if I'm not pronouncing it rightly. Greetings from Mongolia. Thank you so much for your brilliant presentation. There's also a message, Dr. Al Fateh Hassan. You are the one who deserves thanking. Thank you very much, sir. Thank you so much for your message. Dr. M.D. Mushir Rahman, he's a professor in Bangladesh. He's sending you a big thanks and a lot of emojis as well. So there are a couple of messages too. There's also a message just now from Dr. Tungu Jassi. Thank you, Dr. Noor and Dr. And Professor Atul Goel. So there are a couple of questions. Would you like to take if you have time, sir? I know you must be really busy, but
No, of course. Let me answer
so,
the question, whatever.
yes, thank you so much, sir. You always spend a lot of time. I cannot, I cannot be so thankful. There is. Can you show us, sir, there's one message. Can you show us the intraoperative pictures of how you fix C1 and C2 facets? I think, sir, your videos are available on internet.
Yes, they
And
are all available. Maybe next time, Noor, I can have a different kind of presentation where I show some videos. Okay?
exactly. So that will be a huge favor because we always wish to see you operating. Sir, I also shared some of the papers you have mentioned with the audience. I hope that everyone will be able to benefit from those publications. Sir, also Dr. Abedullah wants to know, sir, you are recommending facet arthrodesis for fixation or pedicle screws. Any thoughts on interbody fusion?
I know the whole world likes to do interbody fusion. I also like to do. I told you I described transdiscal screws and tricortical screws. I used to do body screws. But if you realize, if you hold the vertebra in your hand, the body is the most flimsy structure, body. There is no muscle attached to the body. Only longus cola is like a curtain in front of the body, in front of the disc. All the muscles are focused on the back, near the facets. If you hold the vertebra in your hand, the body is the weakest. Second is the pedicle. Then is the transverse process, and then is the spinous process is also strong, spinous process. And then is the facet. Facet is the strongest. If you hold, it is like the whole facet is cortical. Vertebral body is cortical and is not entirely cortical. Facets are entirely cortical. Pedicles are not entirely cortical. Facets are cortical. Even spinous processes are cortical. Even transverse processes are cortical. So the vertebral body can be certainly used, but the fascial screws, because all the movements happen at the facets. It is the point of fulcrum of movement. If you stop the fulcrum at the strong and easy, you see, interbody fixation, you do 3-level fixation, you will take 4 or 5 hours and there is possibility of complication. On the other hand, you do 5 levels facetal fixation, you can do in 15 minutes. I do 3 or 4 cases at the same time. My residents or my associates open for me. Then I go and in 15 minutes or 20 minutes, I do 5-level fixation and then, prepare for bone grafting and all those things and put bone over the area. Easy, not only easy, very safe and very strong and very sure and under vision. I don't think there is any method. It is I have not described transfascial screw. This is not my technique. This is Roy Camille from France has described this in 1972. Unfortunately, this technique has never, picked up because these screws are so cheap. My screws are about 200 Indian rupees, means less than $3 or $4. On the other hand, you put anterior cervical fixation, or whatever screws are pedicle screws, or they are about 30,000-40,000 rupees, or at least $500 a thing. It is not the cost. Believe me, I have worked for poor people all my life. I've worked in public hospitals all my life. Cost has never been a factor, even in my poor hospital. I have used the most expensive things, even for my poorest people, if I think they are necessary. But if I think it is not necessary, even if the person is the president of a country, which I told you, I operated on 2 presidents of country. But that does not mean for president I will use expensive material, and what I believe I do, no matter what.
Sir, this is a very, very, very perfect answer, sir. Thank you very much, sir. Your answers are also so much elaborate that I believe that everyone must have a huge separate lesson, and this is really, really huge, sir. Your answers are even very much insightful, and I think many of the people also just fast forward the lecture sometimes and go to the discussion session to see how many things you actually describe, which are also in very much relevant in clinical practice. So there is also a question here from Dr. Yes, sir. Dr. Hannibal Mola. He's saying, Professor Atul Goel, is it a must to do fusion for Chiari malformation after OCD? How can we manage a patient who has basilar invagination, Chiari malformation, and clival hypoplasia?
The only treatment that is necessary in such a situation is C1, C2 fixation. As I have told you, C1, C2 instability is the mother or the father. All other things are the children, like basilar invagination. Some fathers have 2 or 3 children, like basilar invagination is one child, Chiari is another child, Syrinx is another child, clival hypoplasia is another child, assimilation of atlas is another child. Some fathers may have only one child, like Chiari, or one child of Syrinx, or one child platybasia. So whether 2 children or one child or 5 children, the treatment is one, and that is C1, C2. You have to treat the father, and the children will take care of themselves. So that is my answer. Treat the father, treat the problem, and don't treat the solution. They are all solution. Basilar invagination is natural solution. Syringomyelia is solution. Chiari is a solution of nature. So that is the thing.
That's incredible, sir. Sir, we've got Dr. MD Mushir Rahman with us. He wants to say hi to you.
Yeah, of course.
Sir, I think everyone wants to say hi to you because everyone is so much excited. So again, thank you very, very much, sir, for your time. We have taken a lot of your time after the discussion. Like I'm saying that after the lecture, the discussion on its own is a whole lecture. Sir, we cannot thank you enough for what you do and for sparing your time and sparing your expertise and your experience with us. Thank you very, very, very much, sir. So I believe that it's time to wrap up the session.
Thank you, Noor, and thank you. You know what? I will again repeat. Many of the concepts which I proposed are different. Many of the concepts I proposed are completely and entirely different. What I want these young minds, most of the people I see on the screen are young people. Most of the people I see are enthusiastic people. Nobody wants to waste their time and sit on a Sunday in front of TV unless they are enthusiastic people. They want to learn, they want to know. Imagine if I had shown the same treatment, this and that. This is different. That is why you have come to hear something different. But believe me, whatever I am saying, it is indeed different, but this is the future. So you think about it, read about it, get convinced. If you are not convinced, come and spend some beautiful time with me, and I will take care of you. Okay? No, thank you very much. Best
Thank you
wishes.
so much, sir.
Bye bye.
Bye bye. Best wishes, sir. Thank you so much for your time. Thank you very much, sir.
Bye bye.
Bye. Hi, Dr. Yandong, how are you? How is your little mini me?
He no this no he is not a good boy. He always makes me annoy. I don't know how to say, but
No, it's okay. We were so happy to see him. So he's also one of our team members. So
Thank
it's
you,
good.
thank you,
So
thank you,
good to
thank you.
see him. Yeah, I was so happy to see he's all grown up so quickly.
Yeah, yeah, yeah,
During
yeah,
the
yeah, yeah.
series, I remember him a little baby, and he's all
Yeah.
grown up. I was so happy to see him. Thank you very much for bringing him in the program.
Mhm. Thank you, thank you.
Thank you very much. And I'm also looking forward to starting your series.
Yeah, something unhappy happened last month, and so I canceled my plan.
Yeah.
I'm sorry. I will try to start my series. Thank you.
Yeah, exactly. Please to start your series because we are all looking forward to it.
Okay, I will try.
Thank
Making
you
my
very much. Thank you very much. I
see
hope
you.
that everyone will be happy to see you. So thank you very much, everyone. Thank you everyone for joining. I have sent the attendance certificate, link to receive your attendance certificate in the chat box. So I hope that you all have received it. Thank you everyone for joining us today. It was amazing to have you all with us. The recording will be available on my YouTube channel, which I have already shared. Please do subscribe to my channel as well. So again, I hope to see you all soon in one of the webinar series. Have a wonderful